Namaskar, good morning. Today is our 18 December 2024. Myself, Dr. VIPUL GURJAR. I am the head and the professor of Department of Surgery in VADODARA, Pipadia Medical College. Today, I am going to share my experience and something basic thing about the most Chivate procedure for the piles. Everyone was saying me about this Chivate procedure to make a video and please share the experience. So this is my educational video only and I am sharing my views. I am not pointing anyone or any procedure, so please do not take as a personal thing. This is my result, not anyone else. Okay. So Chivate procedure. It is a wonder technology invented by late Sir Dr. Chivate sir himself. He was living in Pune, Thane. He was practicing in Mumbai. While talking with personally, Chivate sir has given me some clues and some ideas, and I asked also, sir, how you find out this procedure? He said, while doing some surgery, there was a bleeding, and he started the continuous interlocking knot, single interlocking knot, and it was stopped. Then he realized about the this type procedure. So it comes in at, I think it comes in 2006 or something nearby, and he published 116 case paper as newer technique in a journal, and then on India wise it is well accepted. Now thousands of surgeons and thousands of surgeries for the piles are doing with this Chivate procedure. I have sent videos about how to take a suture, what is the position of the patient, and which suture material. I have shared videos separately. Here, this video is only for the discussion how to do and what is the pros and cons about the Chivate procedure. Okay, now what is the magic or what is the principle behind the Chivate procedure for the piles? Okay, first thing, piles is symptoms of rectal prolapse. It's not a disease itself. Okay, constipation is a disease. So because of this constipation, anal cushion is prolapse because of the fragmentation of musculi cutaneae. So it is known as a pile cushion. The theory behind the Chivate procedure as well as in a Longo procedure is the same, reposition of this prolapse. Okay, in a MIPH they are cutting, while in a Chivate procedure we are ligating. These are the major two difference between the procedure. Okay, now further going ahead about the principle of Chivate procedure. Okay, Chivate sir has advocated two row of suturing. These sutures are continuous, but at every bite double interlock. Okay, these two suture, continuous circular suture, we are taking at the two side, where at expected 2 centimeter above the dentate line, then further 2 centimeter of previous one, that means the 4 centimeter above the dentate line with the same manner. Why there is a double interlocking? Why not a single? Why not the single one? Double interlocking prevents the anal stricture, as well as after taking this bite, this force remains at the particular knot only. So there won't be any stricture or decrease a lumen of anal canal. That's why the double interlocking suturing is advised. Now, Sir has advocated the 2 centimeter above the dentate line with the first suture line. So, the aim behind is that the 2 centimeter above dentate line, the surgery becomes a painless because it is not trapping the nerve endings. As well as why the 2 line? Because the pile cushion are supplied by the collaterals. It is not an end arterial disease. The collaterals are like it is a net of the vascularity. If it is an end artery disease, then you can ligate with the single suture or even single row also. But pile cushion are supplied by the collaterals. Okay, they are the cavernous collaterals. So that's why the Sir has advocated to ligate this at the 2 step. Now another question will be arise, because of this ligation there will be any ischemic changes in between 2? No, it won't occur till your needle is going too much depth, then it may happen. Otherwise, in my experience or with the Chivate sir's experience or with the many person who is doing this since many years, there won't be any ischemic problem that in between these 2 suture line. Now, about this 2 suture line and with my experience and my theory, I was using with the same what said by the Dr. Chivate sir. But after doing a many case, I feel there is a less regression of pile mass after the or during the long term follow up. As well as second problem, the patient is feeling more obstructive defecation syndrome like symptoms. That's why now I advocate or I am using this first suture line only the 1 centimeter above the dentate line. Because of this near suture line towards the pedicles, there is a good ligation and that avoids a more constrictive vascularity over the pedicle. So there will be a more shrinkage of piles I got. As well as I do not take a 2 centimeter distance between the 2 suture line. Now I am doing a 2 to 3 centimeter above the first suture line. Because of this 2 distance, some large distance, the mucosa becomes a flattened one, and because this mucosa with the suturing of the Chivate procedure, mucosa and submucosa are fixed with the sphincteric muscle over the sphincteric muscles. And I said you that because of this flat mucosa, distance between 2 suture line increase, then there will be flat mucosa and the evacuation of a stool becomes more easier. And that's why the obstructive defecation syndrome symptom, which are maybe the temporary one, it may be a decrease. because these all the pile patients are subject for a obstructive defecation syndromes. Without, they are not coming. Okay, so the first obstructive defecation will be this the started, then the piles becomes evident. So we need to control this obstructive defecation syndrome in our surgery also. That's why I do the some more distance between the two one. Now, how to proceed preoperatively? As I advocate in my MIPH and all the anorectal surgery, the any anorectal surgery must be think as a routine surgery of intestine. So I advocate the preoperatively anal wash, peg wash, and bowel clearance. So for the good vision as well as to prevent the infection also. Okay. Now, under whatever the anesthesia you like, you do that, give the lithotomy position, then specifically, you have to steep down head, that is a reverse Trendelenburg position, about a 30-degree. In this way, the pile cushion and the mucosa will go inside, and that will not come in a picture while taking a suture. Otherwise, this larger pile mass may hamper your visual surgical field. Okay, that's why this step head down position is very important. Then after, you give the xylocaine massage to reduce or to regress the pile mass congestion for the 30 seconds. Then use a Chivate proctoscope